So let's talk about how we do this in practice. In that IGNITE trial, 60% of patients had visceral-only disease, 20% had cutaneous-only, and 20% had mixed cutaneous and visceral disease. And so clearly, Riad, y'all do this. Y'all are good at this. How does it work in practice at Northwestern?
Yeah, so let me first start by sort of adding to what Sue has been saying, and maybe setting the stage for the IR's role, if I may, Tyler. I think it's very short-sighted for interventional radiology to think that this is just a simple injection and it's not the most sophisticated procedures that we do. I think it's very short-sighted, and frankly, we're here to take care of patients. And these are patients that, to Sue's point, have progressed on everything else. So it's really incumbent upon us to do everything we can to help these patients, particularly when there are new, innovative, and really sort of groundbreaking results that are seen. So that's the first thing that everybody has to be level set from that perspective. The second thing I would say is, as an interventional oncologist, if you're going to be involved in interventional oncology, one of our jobs is to do all of the work, the advanced cases, the simple cases, and to broaden our collaborations with oncology. Not, this is too simple for me, I only want to do the complex work. And so I think, again, this really provides an opportunity to collaborate in a new manner. I mean, I've worked with Sue for a long time, but now with the advent of this kind of treatment, it's even more intimate work and even closer work. And I think all of us really like that. I certainly like that. I know Bobby likes that as well. So I think it really solidifies that relationship. The novelty to this treatment is not the procedure. It is the process and the collaboration and the ultimate, benefit that you're going to pay to the patient. So the reality is, how does it work? Sue's got patients that she sees. Some of them are, superficial lesions that her and her team can inject. Maybe some surgeons are doing as well. And once things are more involved, then that in general will involve a phone call. Now, what I would say, before I go into sort of deeper detail is, I think every center will develop their own algorithm. What works best for you? Because there may be some economies of scale that are present in one center that aren't present at another. But every center is going to develop. And so what I'm discussing here is sort of how we tend to do things. We still need to learn more and fine-tune more, and other centers will do that as well. So once you've identified a lesion, then there's a lot of things to think about. If Sue's got a patient and she calls me and she's like, Riad, there are 3 lung lesions, 1 anterior mediastinal lesion, 3 liver lesions, 4 abdominal lymph nodes. Well, what's the easiest thing for me to do? Do I need ultrasound or CT guidance? Do I want to incur pneumothorax risk unnecessarily if I don't have to? Are those lymph nodes in the abdomen available and accessible? Is that mediastinal lesion too risky to risk sort of a bleed of some sort? And so really the first thing is to look at the entirety of the disease process as to how I can help Sue and her patient. There are algorithms that Replimune has put together in terms of how much of the material you want to inject, a totality. I think it's 10 is the number, 10 cc's. And we're going to be working together with Replimune to develop sort of algorithms as to where you want to distribute the material optimally. I know we'll probably talk about that a little bit later on. But if there are 3 or 4 nice abdominal lesions that I can get to with a needle, I may start with that. There are some discussions that maybe there's some benefit of doing at least 1 liver lesion because of the tumor microenvironment, the immunotherapeutic component of it. Who knows? Maybe there's only lung lesions, and so now you need a CT scanner, and now there's a pneumothorax risk. So the management, and so really, the initial conversation you have with Sue and your partner really sets the stage. If there's only lung lesions, I need a CT scanner slot. I need to follow the patient, get some chest x-rays before I discharge them. And what does discharge mean? Discharge usually for you and I, Tyler, means your discharge follow with your doctor. Well, in some cases, you may be getting your Nevo on the same day. You may be getting something else on the same day. So it's actually it's sort of a process-based relationship that you embark on to really sort of streamline things for the patient. So now, Sue and I have discussed, we've identified the lesion I'm going to inject. Is the patient getting systemic therapy before or after IR, right? That's a process that places can decide on. If I've punctured the lung or the liver, the follow-up or the recovery is distinctly different. If it's ultrasound and superficial, I don't need sedation. So now sedation is not something you need to worry about. The patient can go to systemic therapy much faster. All of these things are important. Now, which lesions do I pick? Well, I need to document the lesions. I need to document them on my ultrasound or my CT. They got to go to PACS. Then we have to have a plan. Who's doing the procedure in treatment 2? Is it me? Is it somebody else? How am I documenting what treatment 2 will look like? And if we want to make sure that we sort of distribute the location where we are injecting the material, then how am I going to document that and relay that information so that my partner in 4 weeks, 6 weeks, 2 weeks, whatever the timing may be, knows that Riad has already treated these 3 spots and the next treatment are these next 3 spots. So these are all very simple, but very important to really optimize, how we're going to manage these patients. And so I start with that just to give you a broad base of things that we think about when we treat these patients, because the documentation is important and making sure that we do what's best from a protocol perspective and from a replicating of the clinical trial approach is going to be very important. So there are a lot of things. These are all simple for IRs, but it's a process that you have to embark on, and that's part of your role as an interventional oncologist. When you're working with oncologists like Dr. Chandra and other oncologists.
I think it was great. I appreciate the call to arms, right? Because I think it's important for us to understand that you don't just get to pass over what's going to, I guess you would allude to as a simple injection, right? I wouldn't compare this as, it's not going to be as difficult as a PVR tips, but it's something that anyone can and should be able to do, right? If you can do a biopsy, you can do an injection. And so I appreciate the call to arms. One thing to highlight before we dive down some questions specific to you is you really emphasized collaboration. And obviously, Northwestern has been very, very successful because you have people that want to integrate across the system. You have medical oncologists that want to integrate with interventional radiologists and interventional radiologists who want to do the same, and then surgical oncology ahead. Y'all have been incredibly successful because of the collegial and collaborative nature when it comes to taking care of patients. And I think that's where we sometimes in the community, and I don't want to speak for everybody, but we sometimes wonder that if we collaborate too much, that we'll lose patients in one arm or the other, right? Like if I start to have people go see my medical oncologist before I do a treatment, I'm not going to be able to treat the patient, and which is a selfish mindset. But whenever you integrate with your oncologist, I think what people fail to appreciate is it's a rising tide rises all boats, and everybody benefits. The patient, most importantly, the patient. But when we approach things from a team and system-based effort, we stand to gain so much more. You wind up doing way more things in practice. And I think when people talk about how do I build my oncology practice, I hear this from time to time. The trick is you integrate as much as possible. You communicate as much as possible.
Yeah. And just to add to that, the patient is at the center. We practitioners, collaborators, we encircle the patient to do what's best for that patient. And that's really the way we should be looking at this. We want to get the optimal outcome, and everything sort of revolves around, what we do with that patient.